ఏ మూవ్ అవుతున్నాయి కదా ఓంకర్, నేను మొబైల్లో చెక్ చేశాను. నీ మొబైల్ ప్రాబ్లం ఏమో. Onkar, if you are able to visualize, we can start actually.
Slide move అవట్లేదు సార్. స్టార్ట్ చేస్తాను సార్ అయితే.
స్లైడ్ మూవ్ అవుతుంది.
అక్కడికి అవ్వట్లేదు అందరూ అయితే.
యాక్చువల్లీ ఇక్కడ ఏం కేసు ఉంది అందుకే పైన మనకి ఎందుకు వచ్చాయి సిస్టమ్ లో చెప్తుంది.
కిందకి వచ్చాను నేను, ఇక్కడ డ్యూటీ రూమ్ లో ఉన్నాను నేను.
నో యూ కమ్ టు ఐసీయూ.
స్టార్ట్ చేసే పని చేస్తుంది. స్టార్ట్ చేసి
కమ్ టు ఐసీయూ ఓంకర్. Okay, meanwhile Onkar will come here. So management of preoperative anxiety in children, because with a few topics we choose Onkar to be the right choice for this topic, because he managed so many pediatric cases in VMC earlier, and now doing a regular OT. We have got so many ENT surgeons in ABC with more of Ednatons. We actually I too have learned so many new points in this talk, like taking an OR tour before the surgeries and some sedation points and all. So let's see what we will learn to the coming 20 to 30 minutes of presentation by our anesthesia HOD in ABC, Dr. Jagdish Onkar. Good morning all, and over to Onkar.
Hello, good morning all. I'm Dr. Jagdish Onkar. Now I'm going to talk about management of preoperative anxiety in children. So most of us attribute many of our health issues to anxiety and stress, and so this anxiety is also related to children. So when I'm dealing with these cases, and one of my child's mother, she asked me a question saying that is there any side effect of your anesthesia or else this surgical stress and all. So because of her, I thought of reading something, and at the same time Srikanth sir also helped me in, by giving this topic to me. So I will try to enlighten some things today, and most of which I did not know frankly, and after reading this topic only I came to know few things. So first of all, let's know what is anxiety. Everybody uses this term quite commonly. This fellow is very anxious, this patient is very anxious and all. So it's a feeling of fear, dread and uneasiness that may occur as a reaction to stress. And a person with anxiety normally they what you call the appearance, they sweat a lot, they feel restless and tense, and sometimes even we notice that our colleague who is very cool and calm, at times they get hyper exaggerated responses will be given, and rapid heartbeat, which patient normally tell that he's having some palpitations at some moment of time, and extreme anxiety that happens often over time may be a sign of an anxiety disorder also. So extremes of anxiety, there is a complete change in personality, and in that scenarios we use this extreme anxiety word. So most of mothers, normally when we are in follow-up, which we don't do, after 2 weeks of surgery, there is a study which quotes that after 2 weeks of pediatric surgery, any surgery, there are few complaints regarding behavioral changes, that is maladaptive behaviors, that is new onset enuresis, feeding difficulties, apathy, withdrawal, and sleep disturbances in children, which normally parents approach the consultant, not the anesthetist. But this anxiety, perioperative anxiety, is the main culprit behind all this change, new behavior in child. So what normally before giving surgery, we can have some anticipation. There are some predictors like age. Normally kids from 1 to 5 years are most vulnerable to this anxiety, and their temperament, and anxiety of child in preoperative room, and anxiety of parent in preoperative room. Parents role is very crucial whenever we are taking a child for any procedure, say it be an MRI or else CT or else a surgical procedure, minor or major. So parents' attitude plays an important role. When we do PSC and ask history with parents, even then we can understand that this child might be a bit what you call uncooperative. So there are too many what you call stimulants for this anxiety. So the patient gets stressed up, and that stimulations can be like fear, anxiety, pain, even cold, major surgery, and even infection. They all can precipitate that what you call stimulate our stress system. What happens when the system is stimulated? The corticotropin releasing hormone and Lucas ceruleus, norepinephrine, these get stimulated. From their hypothalamic pituitary adrenal axis, and from their limbs of autonomic nervous system. So altogether, what happens is neuroendocrine hormones and cytokines, they are released, and they provoke negative nitrogen balance and catabolism, like protein breakdowns, because of which there will be delayed wound healing, which finally lands into immunosuppression, post-operative immunosuppression, and patient will be having infections and all. So before going for surgery and taking proper doing proper PSC, we need to know about psychobiology of separation. Okay, so what is this? It's nothing but learning to cope with separation from parent is necessary for child before we are taking for surgical procedure. Because if the child is able to cope up with that separation period, then it will be helpful for us in to handle the baby in pre-op room. So separation experiences, we ask about is the baby going to school, and how is he while going to school? Is he becoming cranky whenever he need to go to school or not? And how is it once you reach the school, and after 1 hour or 2 hours, how is he behaving in the school? And at times we can see initially children go to school, and after that they get very much agitated. So these sort of behaviors, everything, all are also predictors for what you call our preoperative anxiety in children. So this separation may precipitate confusion and anxiety in them. So identification, children up to 1 to 5 years of age are there at high risk, and children who are shy or inhibited, and children even though they're having high IQ and lack good adaptive abilities, like some children, they will be very good at giving answers and replying back, and once they are away from their parents, they completely do not respond at all. They won't adjust, and previous surgery or hospitalization, poor response to, hello sir. Poor response to visits to the pediatrician, and parental anxiety. It's very important. If parents strong enough and confident, and then it will be what you call helpful to the anesthetist also. The separation part.
Nana, take the citizen.
Sir.
Mohan sir,
Mohan sir.
somebody is not muted, talking.
Hello. So coming to this separation part, ideally first 1 week to 1 month, kids they are like they are comfortable with anyone who are holding them. So when we are doing any MRI pressure or anything for initial 1 day baby or else first few months, so separation is not at all an issue. Next is from 3 months to 5 months, where baby recognizes known and unknown, but they won't be uncomfortable even an unknown person handles them. And from after 7 months, the concept of separation anxiety begins, and this is the age from after which baby identifies what you call new faces, new atmosphere, and they won't cooperate at all. So these things after 5 years, they with the increasing age and all, they learn to adjust, and separation anxiety reduces. Next thing is there are some behavioral modalities like preoperative preparation programs. These programs are age-old programs, but they are not known to us. They started in 1960s, where they give an orientation tour and narrative information, and so that the parents, baby, and hospital staff develop some sort of bonding, so that baby will be comfortable while they are taken for surgery, because the atmosphere will be already shown to the baby, so they don't feel what you call new. And in 1970, the program was upgraded with road rehearsals, like giving some toys or else showing some videos. And in 1980, teaching of coping skills. What they do is like the entire giving OTA, like giving them into their hand as if they are some toys. So currently, the play therapy, operation room tour, modeling, and printed materials. So pictures of previous surgeries of a baby going on and how they cooperated and all, so that it will make children a bit comfortable. And program giving the timing of the program is very much important. If children of age more than 6 years, if they're given program for around more than 5 days, this program is beneficial. And last 1 or 2 days, there are studies showing that not of much difference in what you call anxiety development in children. So next is parental presence during induction of anesthesia. I think Vamshi HOD of Vijay Medical Center better knows about this, because we allow the parent with the child when we are taking the patient for any procedure. So there are some benefits and objections for this. Benefits: it reduces the need for sedatives. We need not sedate the baby in the pre-op room only. We just sedate them in the operation theater or else MRI suite, because it avoids fear and anxiety in the child, increase compliance, and even parent satisfaction. Objection: disruption of OR routine and crowded ORs, possible adverse reactions of parents, because even parents are not exposed to these atmospheres. So when they are exposed to OT atmosphere and all, they might have some problem. There was a case in US where a baby was allowed with their mother for the operation theater, and after seeing all this, the mother collapsed. She had an head injury, and patient relatives filed a case on hospital. Then Supreme Court over there, they gave a judgment that if a patient is being treated and for treatment, if the relative is coming with them, it is okay. But if any hospital staff or hospital any person of a hospital asks to accompany them, and anything happens to that accompanying person, it is completely sole responsibility of hospital itself. And finally, a parental presence, which increases stress on anesthesiologists. And coming to pharmacological modalities, so majority of children use, they are given oral route medication sedatives, intranasal route, IM route, rectal route. IM route is least, actually IM and rectal are very much not done at all. Most commonly used is oral route and intranasal. So coming to midazolam, it's more commonly used. Short-acting benzodiazepines with lipophilic at physiological pH, rapid onset. So there are routes where we give route of administration: oral, intranasal, and rectal. Coming to oral, we give 0.25 to 1 mg per kg with the time of onset of 10 minutes. And intranasally 0.2 to 0.3 mg per kg with onset is less than 10 minutes. But the problem is while giving intranasal space to pediatric age group, they cause burning sensation in the nose, because of which patient get bit agitated initially and then they cool down. Rectal 0.3 to 1 mg per kg and time of onset is 10 minutes. Fentanyl, it's a synthetic opioid, very lipophilic, which makes it a good member for mucosal and which crosses easily mucosal and dermal barriers. And OTFC, that is oral transmucosal fentanyl citrate, available in 200, 300, 400 mics, is administered as eatables to the children. And it is the first FDA approved drug which can be used in children, which is given in 1993. So as I told, OTFCs are available as 200, 300, and 400 doses and mixed with raspberry flavored candies, and they're given to children. The dose of 10 to 15 mics per kg, and its effects starts after 30 to 35 minutes after child consumes it. And its sedative effect is also associated with facial pruritus. Okay, this is a point of worry. And OTFC usage in children, it causes respiratory depression if baby is consuming high dose, and post-operative nausea, vomiting. So post-operative nausea, vomiting using this OTFCs is noticed with even low dose, and very much high exaggerated with high doses, where even our regular domperidone, these medication are also not helpful. Studies said that go for low dose OTFCs, and in post-operative period start antiemetics, even though baby is not having vomitings for around 1 or 2 days initially. Ketamine, it's aryl cycloalkamine, and that produces a state of sedation, immobility, analgesia, amnesia, and dissociation from the environment. So most commonly in Indian scenario, ketamine is being used, but in order of preference, ketamine is last but one for sedations in US and all. Advantages: it causes less respiratory depression when compared to OTFCs. Disadvantages: increased salivary and bronchial secretions, muscle rigidity, nystagmus, post-operative emesis. There was a study conducted comparing ketamine and OTFCs, where even though respiratory depression is low, ketamine was not preferred because the increase in salivations and bronchial secretions. Baby already, even though we follow any method, baby cries and secretions are increased, and with this ketamine injection, secretions are further increased, because of which when we are pre-oxygenating baby, then there is a good chance of all this secretion being enters into our lungs. So post-operatively, cough was predominant in cases where ketamine was used. So ketamine is less preferred nowadays. So same ketamine is also given in intranasal, rectal, and oral routes. Intranasal dose 3 to 5 mg per kg, onset less than 10 minutes. But the same nasal spray causes burning sensation in nose. Rectal 5 to 6 mg per kg with onset 20 to 30 minutes. Coming to oral dose, there is a low dose and high dose. Low dose is 3 mg per kg. Time of onset is 20 minutes. And high dose is 6 mg per kg, which time of onset is 10 minutes. But with the high dose, again, there are increasing chances of having secretions. Clonidine, it's an alpha-2 adrenergic agonist. It has analgesic, anxiolytic, and sedative properties. And it's administered at a dose of 4 microgram per kg. It causes sedation and decreased anesthetic requirement and decreased post-operative analgesics also. The main drawbacks of clonidine is post-operative psychomotor impairment, where for few hours, baby, what do you call, communicating with their communication skills were very much low for first 6 hours using clonidine, and so this was a point of worry, and the usage of clonidine came down. And one more thing is it should be given around 45 to 60 minutes before the surgery, and then only we can take child for surgery. And even if after waiting for 45 minutes to 60 minutes, if what you call child is not what you call anxiety is not reduced, then again we have to increase the dose, and again we have to wait for another 45 minutes. And repeated doses were also causing difficulty of bradycardia with clonidine. So in future, what type of drugs we want, the properties which a pharmacological drug should have if we are using it is it should have antegrade amnesia, decrease intraoperative anesthetic requirement, it should reduce postoperative analgesic requirements, it should be easily administered, while like intranasal it causes burning sensation in nose, IM pain. So these should not be there. It should be easily administered like transdermal patch. Even transdermal patches were used for this sedation, but it took more than 1 hour for making the baby drowsy. And after, even if the baby was not getting drowsy and all, further drugs, their dose should be reduced to 50%. And even then we cannot assure are we going in the right direction or not. So now there are studies going on to increase what you call reduce the onset time with these patches. And least side effects on children, like any like clonidine we had for first 6 hours, their communication skills, and they were not at all properly oriented. And overdose must be antagonized, like if you are using lots of benzodiazepines, we are using what you call fumagenial drug. So overdose must be antagonized. The new drug should also antagonize drug to uh, to be given, because if you are using a fentanyl patch and we thought baby is not drowsy, and suddenly we go for midazolam or anything, if it is having any antagonist, it's easy to recover the baby. If it is not having any antagonist, then we have to what you call face bit of consequences. So this is my class, and I know this is a bit of a dry topic, and most of us deal with less number of pediatric cases. But coming to Vamshi, who deal only with pediatric cases in Vijay Medical Center, I hope we get some few points from this class. Thank you. Any questions, please?
Good morning, Onkar.
Good morning, sir.
If you don't have a MRI compatible probe, what is the best drug in pediatrics for MRI studies?
Sir, ideally we are midazolam, sir, midazolam.
Ketamine?
Sir, ketamine, there is good chance of having increase in secretions, and for MRI, mostly they come with the seizure history, and ketamine increases intracranial pressure, and we are having good chance of having ICP rise. So midazolam is preferred, sir.
You stay with the patient in the suite, or you observe from outside?
We stay, sir, we stay.
What monitoring you do?
So, we are provided with MRI compatible saturation probes, sir. We keep that, and we are having what you call respiratory belt. We use that to monitor chest movements. We use these two, sir.
When we were students in Guntur Government Hospital, our assistant professor used to say, if you get a IV line in pediatrics, 50% of the anesthesia is over. So nowadays, sevoflurane inhalation is helpful in securing the IVs in pediatric patients.
Maybe Dr. Ravindra and Dr. Sharada from LVP are supposed to be here in this class, I believe. So at least you are telling the 50% of anesthesia is over once you give IV line. Raman Prasad sir very rightly said. But they don't even put IV lines, but they give anesthesia. So I don't know how we need to manage the 100% without IV line.
Sir, good morning, sir.
Good morning, ma.
Hello, sir.
చెప్పండి మీ ఓంకారే కదా
Sir, yes, sir. Sir, it's actually for EUA cases over here. What we do is we give only sedation with sevoflurane, sir. We use only sevoflurane because their cases are for like 10 or 15 minutes. So we induce with sevoflurane, we maintain with that, we put an LMA. So it's easy for recovering the baby also. And after the case is done, over here, there's no post-op ward, sir. So we hand over the baby like after 5 or 10 minutes, putting them in the recovery room for like 5 minutes or so. So
I'm
that's the
not
reason,
asking handing over. I'm not asking. As when you put the patient under sedation, can we
Yes,
do
sir.
without IV line? Because that's one question I really want to know. Because
Sir, actually,
Ravindra is online.
no, no, sir. I
Ravindra
don't
phone
think so.
connect
Sir, good morning, sir. Good morning, sir.
Anesthesiologist Manjula ఉంది.
Sir, the same thing was discussed again and again as per the ISA guidelines or the American guidelines. It is not recommended, but only because of the huge load. We waste time in putting the IV cannula. We are doing without IV cannula, but at the same time, there is a strict monitoring facilities we have. And when we start the case, we usually look for the IV line where we can put in an emergency. And another thing is the strict monitoring of the fasting NBO. NPM is monitored.
What is the meaning of strict monitoring, Manjula?
Strict on the ETCO2, pulse oximeter, ECG, everything is monitored, sir, continuously. And because it is a very short period of time.
No, I want to really argue on this. How do you put ETCO2 without putting LMA or intubation or on mask?
That is what, sir. Mask to karte nahi hai. We have only LMA, sir.
Then at the time when you get a complication, how do you manage the patient? My question is that because
no, that's what I'm telling you, sir.
Something dangerous, and without IV line, how can you induce the patient?
That's what I am telling you, sir, because it is a very short-acting drug, and we look for the IV line where we can put it in an emergency. That's what. It is not recommended, but it is being done.
See, the reason is that some practices have been done for years together, decades together. But when something happened, we have to change it. So that's one of the thing. Even that is because of government cases, ROKC cases are more free cases. If the cash patient comes, if any child dies, who's going to question you? Who's going to ask you? Because unethical way of practicing, and we are practicing is because just like, everything we can do under spinal, not GA. This class is not for argument, but this is only for discussion sake. Please kindly understand me. And we all have to be together and say that something better to be done for the department and fraternity. And no complications occur, because anesthesia should not cause any complications, should prevent complications and improve the outcomes. So in that case, I'm deadly against any patient doing it. Maybe even I did many cases. Please understand, I do cases without IV line, but in the reality, what is going to be the future is my worry. That's the only thing.
Yes, sir. We should make a guideline. As per the guideline, we have to follow. Maybe to the institute also, we have to convince that it IV cannula is a.
No, if anesthesiologist, all of us say that no, we have to do with IV line, otherwise it's not good. Very chitran.
Yes, sir. That is true. So, that the same thing is being happened.
That's the only thing what to do.
Yes, sir. Yes, sir. Yes,
Even
sir.
for local cases, it is better to put IV cannula and start.
Madam, good morning, madam. Manjula, madam. Madam, just a small.
Yes.
You said that you will check for IV line before giving sevo.
No, that patent, no, because sometimes that time in
Manjula,
when we are anxious.
That you are seeing, but everybody is seeing that nobody, and the PSC just put the gun, put it in the table and do. Nobody is checking for IV line. Are you sure, Sharada? Are you checking the IV line compulsory before taking the patient inside? Tell me truth.
Sir, for sure we check, sir. Yes, sir. We surely check, sir. And what we do is, sometimes if the baby is more than 3 years old or 4 years old, we counsel the parents, and in front of them itself, we place the IV line so that baby will cooperate.
So what will you do, Sharda, if you cannot find IV line?
Sir, if before starting the case, if you're not able to find an IV line, after putting sevoflurane, then we'll place an IV line, sir, for sure. If we are not sure that we might not find the IV line after inducing, then for sure we'll put, sir. And we have a infant vein finder with us, sir, over here.
Yeah, it is there wherever all the OTs they have, sir. Still in the operation theater, sometimes we postpone the case because we cannot find the IV line and or we cannot access the IV line. It has happened few times because they're all very small babies, 20 days or 2 months, 3 months, less than 2 kgs, and tried many times outside.
No, this is very nice. Actually, the level of class is somewhere where we are doing in UK or USA. But the discussion what we are doing is what we are doing in a very remote peripheries. See, because the excellent class by Omkar, as he said rightly, before starting the class, he does not know many things when he started, and Srikanth has given an opportunity to learn. And because I'm sure Srikanth has given this opportunity because already Srikanth knows about it and he wants Omkar to know about it. So I'm sure, Dr. Srikanth.
Yes, sir. Because when we working in VMC and here, no, sir, and this season we are getting a lot of pediatric cases.
I know holidays. No, see, I remember few cases how you used to handle in the VMC. After this class, your handling in VMC will change, Omkar.
Yes, sir, for sure.
Because giving anesthesia when the baby is in mother's lap is something different. We used to give putting the patient in mother's lap in Nizam's Institute and previously even in when I was in MBBS Manipal also. Madam, I'm sure in UK and every place they do. Here, no sound of the baby should be heard because previously I was really upset with some senior cardiac anesthesiologist and making the baby cry and taking to the OT and forcefully putting the mask and let them cry under the anesthesia till that. So keeping the baby inside coolly does not knowing, like for example, you give IM injection. I used to give IM injection of ketamine and midazolam together with the babies. And once they sleep in the lap of the parents, then I used to carry them inside with the very fastness because that's the most important thing is baby should not know that she is taken inside with the forcefully doing it. And not only this, anywhere, it's comfortable is a mother's lap. So maybe some parents are very panic and they may not accept, but let them be there and do it even at the side. You know, most of the anesthesia cases normally you have a pre-op room doing a procedures, doing a GA, and then they put in the patient to the ID. You can even do the GA for the baby outside, then put the baby inside and start the surgery and come back. That is the best way what I can do. But lot of this, as you said, less than 6 years, more than 6 years, education videos, all this, it takes a lot of time because our anesthesiologist doesn't have that much time, and because we don't get that much paid is a main issue, I feel. So if you pay for one baby 10,000 rupees for anesthetist, he'll be there for entire day and do all the PSC, all the management, and all the post-op. I'm sure I'm about it. Am I right?
Sir,
Anyway.
another thing is nowadays the dexmedetomidine nasal drops also has been shown to be effective in for the child and the mother separation in the preoperative period. Some studies are there on that.
Here, this class is mainly for Sarada, Ravindra, and Vamshi, and all the people, Anuradha, whoever does all the pediatric cases. I think Kiran joined or not, I don't know. And I'm sure this is going to be give us their knowledge, their experience is going to give us a lot of knowledge. What was you used to do in UK? And I don't know what you know.
Sir, when I was doing my DA, which is almost in 2000, that time we used to give that pedicloryl syrup, which was also very smooth separation, like, you know, in the preoperative period from the parents. But nowadays, everybody pull the patient from the mother and they're taking the child inside.
We are following this method, madam. We are using pedicular syrup for months babies in Vijay Medical Center. And if the procedure is being not done, if MRI is not done, then we are not giving any anesthesia for next 24 hours. And after 24 hours only, we are planning any procedure under anesthesia for a baby who was already given pedicular.
You can try this nasal drops, dexmedetomidine. I think it is, you have to just take it in a 1 ml syringe and according to the per kg body weight dose, you can just instill into the or nasal mucosa, matlab just drop it. I think the action is faster with the dexmedetomidine than the pediculoral syrup, but at the same time monitoring is required.
Yes, madam. For plain cases, plain MRI, we are getting over with pedicular. But if any contrast or any positional change, definitely we are going with anesthesia only, madam. We are left with no options.
Yeah.
So we allow the parent and child. We are given a room, and we cannot even make the baby sleep. Just mother will be holding them, and we'll be putting cannula. I think Mohan sir he has a good idea about this. So, and I thought Vamsi will be there in the class and he will add some points. I think Vamsi is busy.
Vamsi is there.
Dr. Vamsi. VMC King.
I think
I like
YVC
to-
and message.
Good morning, everyone. I like to add 2 points regarding this. One thing is, as Ramana Prasad sir said, securing the IV line is the most important part. Once you secure the IV line, half of the anesthesia is over. But securing the IV line without any pain is the big task. Without making the baby cry, without having the patients worried, and finding the vein with on the first attempt
We have
is a very big.
ointment undi kada, Shekhar.
We do have gelatin ointment will not be that much useful, sir, but we do have gelatin and Prilocan sprays now. With the combination of Amla, not like Amla, we are having sprays now, recently launched. Prilocan with lidocaine sprays. We can use them. And one more thing we can do is we can use oral midazolam or we can give rectal midazolam, because every pediatric surgery is a planned surgery. There are minimal emergencies during, I say very less pediatric emergencies, but most of the pediatric surgeries are planned surgeries. So we can actually plan the case before day only, so that how much, depending upon the age, depending upon the activity of the child, depending upon the age of the child. So some people, some children are more active. Most of the children are active between 4 years and 10 years. They will not listen to anybody. And we can't calm them as easily as we can calm a 4-year-old or a 12-year-old. So we need to tailor our pre-medication with keeping in mind that the age of the child and the activity of the child and the underlying disease and the procedure that he is coming for. So if the patient is coming for a hydrocephalus surgery, the baby will be lethargic only. So there is no issues with those kind of situations. So if the patient is coming for a tonsillectomy surgery, then the scenario differs. When the patient comes from a hydrocephalus surgery and the scenario coming from a tonsillectomy surgery, the scenario completely differs. And the anxiety levels are also differs. And we need to calm the patient, the parents also. So these days, most of the parents are so anxious about their kids, because every kid is a precious kid. So they are so anxious, they collapse if they say if we say any negative thing, or we do any negative, which will have a negative impact on their minds, then they will not accept the anesthesia part. So we need to be very careful and tailor-made our plan of anesthesia according to the patient's psyche, at the same time with the parent's psyche also. These are the things I want to share. Thank you.
One last point from my side.
చాట్ లో పెట్టిన మెసేజ్లు అన్ని కరెక్ట్ గా ఉన్నాయి. ఎవరో మాట్లాడితే బెటర్ కదా.
Good morning, Omkar. Good morning, Omkar. Topic is very good.
Good morning, madam. Thank you, madam.
Topic is very good. Regularly, when pediatric case, according to Shekhar told, age and weight of the baby, if patient and sickness. If a baby is very sickness, we directly go for sevoflurane and do put IV cannula and then do what anesthesia you want to give. And the patient is very healthy, and at that time you want to very hesitating means we have to give IM injection. And some babies I am giving glyco with the midazolam combination. So orally I am giving. Orally I am spraying so in buccal mucosa. After for 10 minutes into the OT with the sevoflurane, and I try to IV cannula. That is regularly I am doing previously. If baby is very irritative and anxiety means IM injection and followed the sevoflurane and IV cannula. And after the procedure in post-op, we used to give toys. So every case we are doing sterilization, sterilization. After that, we are entertain the toys and balloons, and regularly we have to do spirometry. So we are giving balloons to blow, and painting books, and what if a baby is drawing capable, and sometimes we are used to give pads and mobile with some video games. uh, we are practicing like this, and I'm practicing like this in during the cannula time also. I'm giving the mobile, sometimes our mobile only. So baby wants which one or which video she wants or he wants, so that playing that video, we are talking and keep putting the IV cannulas. And my question is, how we are practicing regularly, because we are regularly doing pediatric cases. Thank you.
Thank you, madam. Madam, in Vijay Medical Center, we allow the parent. That is only the main thing.
Hello.
We do. We allow the parent and we try to put cannula.
Hello.
Hello, madam. Good morning, madam. Rani, madam. Chappan, madam.
Hello. Can you hear me?
Yes, madam. Yes. Madam, carry on.
Oh, hi, Onkar. Good
morning.
class.
నువ్వు కంప్లీట్ చేయవు నువ్వేదో చెప్తున్నావు కదా, కంప్లీట్ చేయది.
Okay,
అయ్యో,
sir.
సారీ నాకు మధ్యలో వినపడలేదు ఏమి.
Nothing, sir. One last point from my side. Anesthetist attitude while handling the baby is very much important. And one thing is, at times we fail to put cannula. Please don't keep on poking around 4 to 5 times. Take 1 or 2 try chances, and after that either call senior or what you call or else cancel the case for that day. Take it on fresh day, but don't keep trying for 4 or 5 times, because of which baby will be anxious and parents will be anxious and entire scenario will be like disturbed. So if it is a failure, accept it and tell to the parents that it is a difficult cannulation and I'm unable to put. You can come for tomorrow or else call your senior. Thank you.
Sorry, one more I'm adding, because when you are doing the PAC only, that time only you have to check you can able to put the cannula or not. You always check the right and left, or sometimes you have to check the leg also. During PAC only you have to check. And when patient entering the OT, so you want to give oral or IM injection, before only you have to check the you are able to do or not. After that only you want to cancel or not, you have to decide. Otherwise you can see the external jugular is able to see or not. After that only you can plan for any anesthesia, oral or IV or rectal or nasal or anything.
చెప్తున్నా రాణి మేడం.
Hello. Yeah, we used to give midazolam oral like an hour before on the ward in little bit of juice or something, flavored drink, sugar drink. Used to give midazolam, and on the ward itself, staff look for good vein site and they put EMLA cream. 2 places they put usually, because 1 place we may not get. So 2 sites they look for. Wherever they see a good vein, they apply EMLA cream. It has to be done hour before. Sometimes they say for some reason, like if EMLA cream is not put long enough, they inform the theater EMLA cream is applied only 15 minutes back. So in that case, we move the case back. So allow it to work. So like that, it has to be EMLA cream. It has to be some kind of usually midazolam oral in juice. If it is a big kid like 8-year, 10-year kid, we used to use temazepam pre-anesthetic for adults. So we used to give the same half dose to the kids if they are older enough and they can take the tablet or mix it in the juice and give it to them. So and also counsel the parents. And we tell any one parent can come to anesthetic room. So, and we also explain that they have to be brave and they should not be they should not get into tears in front of the kid. So whoever wants to come, let them decide, and one parent can come inside and they stand by, or if it is a small baby, they sit on a chair and we hold the CO mask. I mean, while talking to the baby, while talking to mother and looking at the baby, and usually pediatric theater anesthetic rooms are all painted with floral or Thomas Tank Engine or some whatever kids have, the kids program pictures and all those things. So they'll be looking around, and meanwhile the anesthesia technician they look for the vein while just talking to them and checking the kid ID and all. So meanwhile, if it is a baby, we hold the CO mask, and at the same time, technician would be looking for the taking off the EMLA cream out and get the vein ready. So as soon as like a little bit under, and as we all said, monitoring is important. Has to have like a pulse ox probe, and to the mask we attach CO2 thing, inline CO2. So that will be showing how the baby is breathing. So once the baby is little under, you know that tachycardia is going down a little bit. So then we swap. Technician will hold the mask and we put the cannula. So that's how it is done for the small kids. If it is big older kid, if they understand, and we take the EMLA cream off and put the cannula in, they won't feel. They are scared, but they allow you to do. But then they say, oh, it's nothing, didn't feel a thing, like that they used to say. So EMLA cream really does work well. I don't know why we are not using in India. I don't see EMLA cream much at all here, but it does work. So, and sometimes the kids are so panic and anxious, they just curl around, they go prone and hide their hands under their tummy, and they don't turn around at all. In those cases, you convince parents, convince everybody, convince, but they don't get it done. For those kids, we used to send them back and give a bigger dose of some pre-anesthetic on the ward and then bring them over. So that's how we used to do. They won't allow to put the mask on. They won't give their hands. So some kids are really difficult kids. So as Omkar said, they'll have to come back again another day. But anesthetic room separate from OT, so they don't get so much scared seeing the room. And they have all friendly pictures, and usually if it is a small 2-3 year kid, they are very attached to some kind of their own toys, soft toy or some train toy, whatever it is, or a rhyme book or something. Allow them to get it to anesthetic room. So they usually bring their own toy to the anesthetic room. They hold it in their hand till they go to sleep. So that, I mean, like, it's a good experience anesthetizing a pediatric group over there, but it is little disturbing to anesthetize them here. Little bit different conditions here, and no EMLA cream, no anesthetic room. So sometimes it's little difficult. Yeah, as everybody said, getting the cannula itself is a big thing. Thank you. I think at least where we do regular pediatric cases, some surrounding, some ambience, kids-friendly ambience should be made. Then they won't be so scared or worried. I mean, actually, pediatric cases, when they have anesthesia and surgery, they have some psychological effect later also. So if their experience is good at that age, they won't have that trauma effect later in their life. So that's there, that everybody knows, and there are studies that stress disorder they get, some of the prone kids. So we have to look into those aspects as well. Thank you.
How do you manage sedation in neonates with Down syndrome in radiological suites?
Hello, sir.
Sir,
For whatever case you're dealing, especially with Downs, with attention deficit children, completely MR children, and apprehensive children. Ideally speaking, what we are doing in Vijay Medical Center, we don't have all those gadgets and sedation techniques which we follow regularly. So we have to encourage what you call parental presence when we are inducing, and looks bit harsh, but we take an IV line forcefully and start with anesthesia drugs. The anesthesia drugs, sir, and especially most commonly we use midazolam, sir. And in severely uncooperative patient, we even use thiopental sodium.
do you have any experience of intraosseous administration of drugs?
No, sir. Intraosseous, I have not experienced it, sir.
Anybody in the group?
Yes, sir. Actually, I think in the shin and the lower end of the knee, around the knee joint, I think they on the tibia only they inject. They have it is like a bone marrow gadget which we have to prick it and give injections, and that is mainly used in pediatric patients only.
It's the upper end of anterior aspect of tibia, Manjula. And
Yes.
the intraosseous needle is quite thick one. It has like a screw kind of thing. So you have to twist it and insert it. And once you pierce the hard bit of bone and enter the marrow area, like you feel that give way feeling, then you know you are in the space.
Yes,
so
yes.
then you can give.
Yeah, resembles like a bone marrow puncture needle.
Yeah.
With a screw, and so that we can adjust the depth. And there is an opening so that we can connect the drugs.
Madam, I think you can do only this procedure with inhalation anesthesia only, madam. For awake child, can we do this?
Again, it is painful procedure, no? This is only for emergency purpose when we cannot get the IV access or something like that. Drugs also can be given. It is just for an emergency rescue.
I thought RP sir was asking about MRI suit and intraosseous, sir.
No,
emergency only for emergency.
Okay, sir.
No, even in emergency.
We have experience of giving intravenous access in scalp in scalp, if it is difficult in limbs, we can put cannula on the scalp veins.
Okay, sir. Thank you.
During PG time, in pediatrics, if IV line not available, we kept forehead region one cannula. In one case, we kept chest region also. What about Vamshi experience?
I think Vamsi is in case, madam. He's not lifting my call.
He is not at care. Hello.
Okay, how you are managing pre-op? Only midazolam only, or any other drugs you are using? I mean, ketamine, IM injection, or any?
No, madam. No, we are not using anything IM or anything, madam. So what we do is we allow mother, and nowadays what I'm noticing is giving mobile phone to kids will help us a lot. Even they don't want mother, but they give them mobile phone, they will easily come into OT. Out of 100 cases I've done, around 50 cases they came directly with the mobile phone only. And we directly take IV line, madam, especially in VMC and all. We directly IV line, start with our injection drugs.
How frequently you are giving midazolam? How maximum? How much dose you are going?
Maximum 50% of for less than 1 year, madam. We are using around 50% of baby's weight. I'm talking about total dose during the procedure, madam, not induction dose. I'm talking about total dose, and we even use thiopentane also for very irritable cases, where we give around 2 mg per kg dose we are using thio, and 50% of baby's weight in if the baby is around less than 1 year, then we use 50%. If baby is more than 1 year, then we use only 25% of baby's weight, madam. We give midazolam. This is how we are following.
What are the complications did you see? How you are rectified?
Complications, we have seen respiratory depression times, and most commonly they will be in lighter planes only, madam. And at times because of tongue fall and all, they'll end up in airway obstruction and breathing difficulties. We do nebulize. By touchwood, until now, from last 1.5 years, I have seen one baby where we had a bit struggle. It's from Rainbow, I guess, and we give I mask ventilated the baby for around 20 minutes, nebulization, and then baby recovered, and we canceled the case, and after 3 days again we took the case and we did the MRA.
Why nebulization?
Because baby was having cramps, madam.
Okay, you are giving hospital,
Yeah, booty card, madam. Booty card nebulization.
BD card nebulization.
Yes, madam.
That procedures are done only under sedation. Omkar?
Madam?
Only under sedation you are doing?
Yes, madam. All MRI and all we do under sedation for children who are not cooperative, madam. We give pediclor syrup for less than 1 year. And for babies like spina bifida and such cases where we need to change position during MRA. So for that we go with an anesthesia only, madam.
But only midazolam?
No, madam. We use midazolam and thio and even propofol also.
I think better instead of thio and propofol, you take dexmedetomidine. It's a very good analgesia and sedation plus no respiratory depression.
Yes, madam. But
Try.
trials on less than 1 year pediatric use of Dexmed it's still under trials, madam. Very
No,
few
not
number of
less than 1
these
year.
things
More.
are,
Yeah, not less than 1 year. More than 1 year, I think it's the best drug.
yes, madam. We can use.
You titrate along with midazolam. It's very nice.
Yes, madam. But the other issues like availability.
Pardon?
Availability, man. Availability of Dexmed in some setups. In our setups, we do have, so we are able to do. We are trying it.
Yeah, I think you can just give minimum doses along with
Yes.
midazolam. It's very good.
Okay, madam.
You want to give bolus, huh? And with the
What?
dilution with the midazolam, dexamide.
You can keep it you 10 micrograms per ml. That is available in 100 micrograms per ml. You dilute it to 10 ml, micrograms per ml. Then you can give intermittent, like in between anything. Anyway, the infusion doses are there, but now we are, because of our affordability problem, you can just give in between whenever there is a requirement. The child is moving or something. 5 micrograms, 10 micrograms, depending upon the kg. Per kg
So
body.
when you're giving bolus, immediately it comes, intermittently when you're giving.
Pardon?
Immediately that action will come.
Yeah, it is very good drug. Heart rate comes down, but no less the respiratory depression. Very nice. It's a good analgesic also. And tachycardia, mainly the tachycardia settles down the heart rate also. But we have to monitor. Heart rate monitoring should be there.
I think Vamshi is available now. Vamshi. Naina.
Thank you.
Thank you, Omkar.
Thank you, sir. Thank you.
తొందరగా చెప్తే నేను లోపలికి వెళ్ళిపోవాలి, నాకు క్లాంప్ ఆఫ్ అవుతుంది.
గుడ్ మార్నింగ్.
వంశీ సార్, ఫాస్ట్ గా చెప్పు.
వంశీ ఉన్నాడా?
ఉన్నాడు సార్, ఉన్నాడు. ఐవి క్యాన్ లో పెడతాడు సార్ క్లాస్ అవుతుంటే.
ఓహో, అది ప్రాక్టికల్ గా ప్రాక్టీస్ చేస్తున్నాడు.
వంశీ
ఏం మాట్లాడండి, చేస్తాడు.
చెప్పు వంశీ.
Sir, in my experience, doing pediatric cases in VMC, putting cannula is the main thing, sir, than giving sedation. And sometimes with monitoring MRI compatible pulse oximeter, sometimes they won't work. So clinically, sometimes we use the respiratory belt, which is used to tie for the baby's abdomen. So we can, by monitoring the regular pattern of breathing also, and in between palpating for the pulse, we can do the cases.
We use it to put a cotton ball on the jiffy sternum.
Yes, sir.
And
we do that, sir. We do that for every case, even now. And respiratory belt helps us a lot, sir, because any increase in respiratory rate, it's an indication of giving some more dose. And we look for duration of the pressure, around 5 more minutes or 6 more minutes. We go with one additional dose, and we come back. This is from outside monitoring. Even inside monitoring, we follow that cotton method only, sir.
I think for this ETCO2 monitoring would have been much better, no? Sometimes under the mask we put that ETCO2 channel cable whatever that ETCO2 monitoring, that would help, I think, instead of using this cotton or paper. Is it available that ETCO2 monitoring MRI compatible?
MRI ETCO2 is not available, madam. And I think when we are having breathing respiratory belt, I think that will do its job, madam.
అదే నిన్నటిదే కదా.
వంశీ మ్యూట్ చేయి. Any more questions, please, seniors? So I think we had a good discussion apart from my topic. Thank you all for your patience listening. Thank you.
Thank you for the nice discussion, also for everybody's participation.
Thank you.
Thank you, Omkar. Thank you to all.
Thank you, Srikanth.
Thank you, sir.
Omkar, last question. Can I ask?
చెప్పు.
లద్దాఖ్ వస్తావా?
లత ఎవర్రా?
లద్దాఖ్ వస్తావా అని అడుగుతున్నాను.
ఓ లడాఖ్. లేదులేబా.
మళ్ళీ అందరి ముందు అడుగుతుంది ఎందుకంటే మళ్ళీ అడగలేదు అంటాను.
సరే.